Welcome everybody. Welcome to this Global Action on Men's Health webinar. Wherever you are in the world, and whether you're watching us live, which I hope you are, or joining or watching the recording, you are, of course, very, very welcome. This event is taking place as part of World Public Health Week, which is run by the World Federation of Public Health Associations. And we're very pleased to be able to support the work of WFPHA. It's an organization that we work closely with, and we're developing a very strong relationship with them. And we're delighted to support this week, as I say, not least because the theme of Global Public Health Week 2025 is equity. And if you want to find out more about the week, you can see the link there on the slide. Equity is obviously central to everything that Global Action on Men's Health does. And we're very lucky, I'm very pleased to say that our chair, Professor Derek Griffith, who I'll introduce properly in a moment, is one of the world's leading experts on men's health equity. And he's published not only a book, but many important papers on the subject. A few words about Global Action on Men's Health. We were launched in 2014, and we became an international charity based in the United Kingdom in 2019. As many of you will know, we're an international network. We have over 80 organizational and individual members. Most national men's health organizations are part of our network, as are many researchers and advocates in the field. And if you're not already a member and you'd like to join or find out more about membership, please go to our website. You can see the link there at the bottom of the slide. You'd be very, very welcome. Our mission is a very simple one, but a very ambitious one. It's to create a world where all men and boys have the opportunity to achieve the best possible health and well-being wherever they live and whatever their backgrounds. And our main goal is to influence public health policy at the global and national levels. And we support an approach to health that takes full account of sex and gender in order to improve the health of everyone. We don't see us involved in a binary issue, choosing between men's health and women's health. We're interested in putting gender on the public health agenda. A few housekeeping notes. If you haven't already done so, please sign in using chat. Great to know your name and your organization. Please use the chat box to ask questions, make comments, and share thoughts. And please do take part. I'm going to hand over to Derek in a minute. He will talk for 30 to 40 minutes, and then there'll be plenty of time for questions and discussion. So please get involved. This webinar is being recorded and will be posted on the Global Action website and YouTube channel, and the whole webinar will last about 60 minutes. So without further ado, I'm delighted to be able to introduce Derek. He's a professor of population health and health equity at the University of Pennsylvania in the United States. And as I say, he's published extensively on men's health equity, and he's also, of course, chair of Global Action on Men's Health. At that point, Derek, I will hand over to you. I'll just stop sharing and you can open your slides.
Okay. Well, good day, all. It's truly an honor and a pleasure to be here with you and to be able to share some thoughts with you. Happy Global Public Health Week. Thank you to the World Federation of Public Health Associations for working with us, co-sponsoring this, and clearly thank you to my colleagues at Global Action on Men's Health. And I should also mention Men's Health Network, who I'm also on their board as well. And the American Institute of Boys and Men. So let's just jump right in. We're in a very interesting moment. I mean, it's kind of hard to figure out how to capture characterize the world that we're in without talking about the elephant in the room of the politics of the moment that we're in. And I don't want to dismiss, ignore that, but also realize that we have to find a way to be responsive in this moment, to think about how we're going to continue to do the work that we do, how we're going to continue to advocate for like-minded groups and those whom with we share particular beliefs, values, and approaches to this vision of achieving population health equity that includes optimal health for men as well. So there are many others who've talked about, and so I won't get into too much about some of the orders and just other changes that have been happening, particularly in the last 3 months, particularly based on what's been happening in the US and how that's driven a lot of global changes. But it clearly has been significant, and it's been important for us as Global Action on Men's Health, for me as a researcher who's interested and committed to health equity, to recognize the need to be supportive and engaged with these issues, and supportive of my colleagues who've been directly affected by this work. As one who's also studied social movements, I'm also reminded that it's important to speak out and speak up during these kinds of moments, because it's not just the words that are directly harmful to some or the actions that are directly harmful to some. It's also the indifference and the silence of those who we considered our friends when we have these moments that we are not attentive to. So I want to also acknowledge, and again, stand in solidarity with all under this large umbrella of men's health, and we'll talk about that in just a minute, but also my colleagues in the gender and health space, women's health, LGBT health, again, all who have been affected by these different policy changes and different movements, both in terms of our global economy, as well as just some of the global political changes that have occurred recently. Today, I want to make sure that we just talk about some of the unique challenges of where we are in terms of men's health, and particularly as it relates to men's health equity, and think about what does this mean for how we need to move forward. I've been fortunate to, and I'll mention also that there's a Lancet Gender and Global Health report that was just released yesterday, I believe, or 2 days ago. So I will briefly try to mention some parts of that. I cannot say that I fully digested the various pages and depth of what they did. It was, I'm sure, quite a Herculean effort. And nonetheless, there are spaces where I want to reflect on, at least mention, the ways that men's health is represented, characterized, and included or not in that particular document as part of this larger conversation. What I was starting to also say is that I'll also mention and want to acknowledge colleagues that I've worked with on a hopefully forthcoming series, knock on wood, that will be on men's health in the related journal to the report. And so I want to acknowledge them from all over the globe where they were. I don't want to try to list them all because it would take a long time, and there were probably about 20 or so co-authors on the various papers, but you will see mention of those throughout the presentation as well. So I want to talk about the 3 things that we want to try to do is to lay the foundation of what are some of the factors that we need to consistently think about, deal with, and recognize that are part of the foundation and complication of men's health and health equity as we continue to do this work going forward. And what are the persistent challenges, or some of them at least, that we face in doing this work and balancing these issues? And then what are some of the opportunities going forward Some of them may not feel immediately like opportunities, but nonetheless are that, and we can figure out how we want to individually and collectively respond in this moment. So as far as challenges, I just want to lay the foundation, and this is from Jim Caddo, who is part of that team from the Lancet series that I mentioned, or led one of the leaders of that team. Dr. Caddo, in this paper was laying out basically the foundational sort of epidemiology of men's health, and this won't be a terrible surprise to most of you who are familiar with this area. We know that consistently across the globe, men's life expectancy is shorter than that of women's. And while everybody's life expectancy is increasing, the gender difference is also widening. And while we've seen some progress in various areas, in addition to that, women's health has been improving in ways that are faster than that of men's. And some of the largest gaps are in various parts of the world, Central and Eastern Europe, Central Asia, Sub-Saharan Africa, and Latin America, when we compare them to some of the other places like US, North America, Western Europe, and Australasia. And we still see one of the things that's important about men's health, and again, why it was founded in the first place, was because of the issues of health equity in terms of, or issues of men's poor health relative to women's and men's poor health just in general. And what we see when we look at those kinds of issues is the primary causes of those sex differences have always been and continue to be non-communicable diseases, particularly cardiovascular disease and cancer. And then we also, have to think about some of the other things that in this context we characterize as external causes, everything from suicide to traffic accidents. Certainly we saw HIV and COVID being something that continue to be major issues in our lives and in our world, and substance use being something that also has been a chronic problem that helps to explain the sex and gender difference between men's health and women's health. We know that particularly when it comes to mental health, that while women tend to have higher rates of poor mental health and higher rates of things like mood disorders, including anxiety disorders and so forth, that and more therefore been infected over the life course a lot longer, more disability adjusted life years than men, that men's rates of dying by suicide are far higher than women, and particularly when we're talking about men under the age of 50, that globally this has been a persistent and chronic problem that we've not figured out how to address and how to consider. And arguably one of the ways that we have not dealt with that is by not recognizing it as a gender phenomenon, and certainly not recognizing how gender interacts with other factors, which are going to be critical to how we think about these issues in the context of health equity. We know that in the context of war and conflict zones, in the context of the paper that Dr. Caddo led, we delved a bit into, or at least mentioned, Rwanda, Syria, and other war and conflict zones, since that is, again, unfortunately, part of the context of the world that we live in this moment. And while there are many ways that women are oppressed in these environments and face considerable adversity in these spaces, we do know that men tend to live 10 years shorter than women in those spaces. And so it is important to, again, not play this competitive oppression Olympics kind of game, but to recognize that we need strategies and approaches that will help us figure out how we need to lift everyone, but how we need to lift everyone given the unique context and issues that their health and their social and structural context represent. One of the things that is important as we think about context and strategies is the fact that we treat this sex difference, and I keep going back and forth between sex and gender because we often think about or measure these and characterize them as sex differences, but we know largely a lot of the determinants of the difference and of men's health are not biological. They tend to be more social and based on men's experiences in the world. And so gender reflects that latter social experience in the world. Sex reflects more of that biology and foundation. Many scholars think about and talk about sex, gender, and the need to think about the full biopsychosocial set of factors that influence health and well-being and how we need to understand those factors. And the point of raising all of that is to say that we treat in this moment this sex difference in life expectancy as though it is normal, as though it is commonplace, as though it is something that we've kind of accepted. But it is something that when you look at health over the 20th century, it's something that really emerged over the course of the 20th century and on into the 21st. And so it is not something that is a definite, it is not something that is biologically driven. It is something that has to be understood in the context of the social, structural, political world that we live in, and how those factors have shaped and created these differences and exacerbated them over time. One of the key ways that we see this is heart disease is the leading cause, again, of death for most populations in most contexts, and certainly is the main cause that's associated with this excess male mortality. And that has, again, increased over the course of the 20th century and on into the 21st. We know that much of that is attributed to smoking. And while we know that smoking obviously is related both to heart disease and cancers, particularly lung cancer, that it's important to recognize that this has been one of the major attributable factors to these issues. And as we think about the ways that in the context of cancer, how men have been represented or included or not, in policy documents, we've seen that we've struggled to figure out or to identify where men are represented and included in these policy spaces. And for many global organizations, Global Action has been able to commission several reports that I'll mention in just briefly later that have highlighted the fact that men tend not to be explicitly represented or well characterized in these documents, and the issues and needs of men, even in areas where men tend to fare worse and tend to be the disproportionate rate of folks who are affected by this issue, like lung cancer and like tobacco utilization, that those factors have tended not to be framed as men's health issues, or where we create specific policy strategies or programmatic strategies or even metrics of success that consider the fact that there is this gender difference where men are doing worse. And we've seen this pattern consistently across mental health, cancer, as we started here, primary care, and sexual and reproductive health. And while I've gotten pushback that I'll mention a bit later for saying things like we should be able to promote men's health, whether it's sexual reproductive health or other areas in and of itself. And for some, they found that particularly problematic, and that we should only be focusing on certain areas of health as it related to men being vectors to women's health. I nonetheless stand on the fact that I think we should be able to promote men's health for the sake of men's health, and consider the fact that it has implications for population health, women's health, and other sort of factors as well. So to say it a more crude way, I think we can walk and chew gum. I think we can do these things simultaneously, but it has been a challenge to get men attention to men's health in this cancer space as just one concrete example. Cancer and tobacco utilization space, to frame it as a men's health issue would be particularly important. In the context of the global sort of picture, this was something that the recent Lancet report specifically highlighted as one of those areas where men were particularly faring worse, and tobacco-driven mortality, again, mostly from cancer and heart disease, were consistently higher than in men than women. And you see this persistently across these different contexts of the world and consistently across each of those. And despite them, we didn't take, or you don't see, and they specifically documented that there were very few interventions that took a gender justice approach, or one that this is a term that they utilized throughout the report, that considers how gender needs to be factored into this in a way that helps to promote a full understanding of gender and its intersection with other factors, but does still center gender in a lot of ways, and we'll talk about those issues in just a minute. But that part of this issue is that we haven't sort of centered men or gender in this particular approach, and particularly where men are doing worse. And so tobacco control would be one of those where it would be particularly helpful and important to think about gender from that perspective. One of the other things that would be particularly important is to think about gender and in its relationship to race, ethnicity, and other factors. Now, clearly, race and ethnicity are not the same across countries, across the globe, but they are relevant as examples and markers of and proxies for who has opportunities and who doesn't within a particular historical and structural context. So whatever the appropriate caste, context, demographic marker, proxy that makes sense in a particular part of the world, it's important to look at that in relation to gender and as it relates to men's health, as we're going to think about which are the populations of men that we need to focus on and attend to. It specifically allows us and facilitates our ability to look more precisely at who's actually faring worse, that men are not a monolith, men are not homogenous, and tobacco utilization, cancer risk, cardiovascular disease, and the ways that these cluster are perfect examples of that. What I want to highlight here is from the US context that I think makes a good illustration of that. And these are data from the American Cancer Society, the most recent data that I believe I could find, where it highlights that not only are there, well, we know that, again, men have higher rates of lung cancer than women, but also men have far higher rates of mortality from lung cancer than women. So one of the bad jokes, well, it's not bad jokes, but it's often a factor that I see. I don't know why I see it more in cancer. Maybe it's because I'm reading more cancer work and I do more in the cancer space, where you have these comparative scales, where you have the x-axis of the rates of men and women's cancer rates, and you see the scales are actually quite dramatically different. When you look at this visually, you would think that the rates of, say, lung cancer, as we're talking about, among Black Americans, when you compare Black males to Black females, would roughly be the same. But you also, if you look more closely, will see that the scales are actually 3 to 1 different, where the scale for men goes to 140 in the rate per 100,000, and the rate for female only goes to 45. Now, from a transparency standpoint and communication standpoint, it would make sense for these to actually be on the same scale, but then you would often see, a compression potentially of women's health in this space. I don't know, I wasn't there in the room when they decided to do this, but I've seen this consistent pattern in the ways that we present a lot of data, particularly when we present sex differences and we present males and females differently and yet present them next to each other. These kinds of ways of framing and presenting data are problematic because they misrepresent and they misrepresent and help people to misinform people, is the word I'm looking for, about the nature and the scope and the scale of the problems that we're talking about, and we've got to do better with that. But this also, again, highlights that it's not just gender, but it's also race and gender, and this idea of focusing on intersections becomes really important. And when we think about it's not just the outcomes, but it's also thinking about it in the context of the commercial determinants of health that we've started to see more explicitly named as one of the social and structural determinants of health. And without getting into the weeds of this, one of the unique things we know about tobacco utilization and problems and issues and barriers to cessation in the United States, and particularly among Black Americans, is the targeting of menthol cigarettes and menthol to Black men and, well, to Black Americans. But again, particularly since we know that most of the smoking has been in Black men, it really would be helpful if we thought about this as a men's health issue and a Black men's health issue, more so than just a Black American issue. And yes, there's a need to recognize that Black men are not the only ones who are smoking, but certainly of smokers, the preponderance of them are actually Black men. And so how we would utilize a gendered approach that considers both race and gender is really instrumental in how we would think about designing a strategy that would allow us to more precisely intervene on the problem that we're seeing. But the fact that we've tended to avoid or just choose not to look at these issues through the lens that allows us to see it most clearly has really hindered our ability to address issues like tobacco utilization. The second thing in terms of considerations, so that was the challenges. One of them, of course, being the persistence of the data, or some of them being the persistence of the data, the challenges in how we present the data, and the typical pattern of not necessarily considering things from an intersectional standpoint. You'll see that continuing throughout a theme throughout this presentation. One of the other just examples I tend to like to give is this idea, again, I sort of highlighted or alluded to it in the first part, that life expectancy for everyone has improved dramatically over time. This is the US context, but this, I think, mirrors much of what we've seen globally, that folks largely are living a longer life than we have seen, 120 or so years ago. The point here is that we see two things. Just as we were talking about before, the sex gap among white Americans and among Black Americans was relatively small in 1900. And you can just see visually that the gap grew dramatically over this 121-year period. One of the other points that is critical to make here is that the racial progress that we've made has been quite significant. We've seen, this is kind of like golf scores. I hate to just use sports analogies, but in this case, it's useful, that lower scores improve, the gap closing is what we're trying to achieve. We're trying to see these things converge while we actually improve health for everyone. And that the racial differences, we've actually seen significant progress in terms of life expectancy over this period of time. And we've seen this gap grow, shrink quite significantly over this long period of time. One of the things that is most striking in showing these data is that the sex difference among Black Americans has actually grown at basically the same amount that the racial difference has actually shrunk. And so the point here is that you can see this multiple ways, that we can ask a lot of questions from this. Why is it that we've seen such dramatic progress in our society in terms of life expectancy and related factors, but we've also seen such that it's heavily gendered and sex, meaning that we've seen most of the progress that we've seen, particularly when it comes to racial and ethnic groups, that are mostly driven by the progress that we've seen in women's health, more so than we've seen the progress in men's health. And when we just look at racial and ethnic data and don't disaggregate by sex, one of the things it does is mask the difference in the poor health of men within those groups. And it's really men within these groups that we really need to pay attention to if we're going to improve the health of that particular population. And I think we have to look at this, that this is particularly critical in the way that we think about this. We saw this pretty consistently in COVID as well. When we think about men's health in a global context, and unfortunately I'm using data from just the high-income countries, and we saw some of the more global data earlier on from Dr. Cato's work, that we see that building on this point, that the changes in life expectancy during the COVID period were dramatically different for men and women. Again, you see the importance of looking at the scale. In this case, the y-axis, where the scale for women only went to 4, -4, and the scale for men goes to 5. So you have to really stretch the scale for women to basically see that the gap, that you're already seeing differences if you look across these particular groups, and the patterns essentially being the same for men and women, where the US is at the bottom of these 22 high-income countries. But you also see that Black and Hispanics within our particular country context are faring worse, and Black and Hispanic men are the worst among those groups as well. We don't do a good job of capturing data on Native American men, and so they would probably actually fare even worse than Black and Hispanic men in these contexts. But because we don't prioritize capturing that data and presenting that data, I don't have it here. But it is important to, again, lift up those groups that sometimes remain invisible by the sheer fact of how we present the data and what data we present. But the point here is, again, using a gendered approach should consider these kinds of factors, should consider issues like life expectancy, should consider issues like cardiovascular disease, premature mortality, these bigger picture factors, not just issues like tobacco use, behavior change, HIV, those kinds of factors, that we have to consider these things that we use as large metrics of the health of a population. Life expectancy, premature mortality are some of those that we use at that level, yet we don't tend to report these and present these from a gender perspective. This is just these reports that I was mentioning earlier that we've done that have shown this consistent pattern of how men are characterized or mischaracterized in global policy documents. That often we've seen, one of the themes that we can say is consistent across the 4 reports that Global Action has done in the last few years, is that we've seen this pattern where we looked, the authors of these reports looked at, how are men included, or if they're included in these reports explicitly, and how are they characterized in these particular reports. One of the things that's important in that context is, if men are doing worse, how are they discussed? Are there specifically recommendations and goals and objectives set for men, given that they're faring worse in these particular areas? The short answer is we saw very few examples within and across these 4 key areas where men, when they were doing worse, that we actually set goals and objectives for men, or actually had explicit explanations for those, or things that really took into account the larger context other than things like masculinity. Very similarly, one of the things that the Lancet report showed is that this pattern of equating gender and looking at gender primarily as something that was synonymous with women's health is something that colleagues of mine at Global Action on Men's Health has been trying to work against for a while. Other colleagues who are in the men's health space recognize as something that is problematic, because it, again, renders men's health invisible in these particular spaces, and even more so renders men of color spaces or marginalized men in these various spaces as even further invisible, because there's no way for their issues to be presented in these contexts. And whether you're talking about men in, again, war zones and so forth, if we don't sexually segregate the data and don't have the data intersect with sex and gender by some of these other factors that are important in those contexts, we're going to continue to miss the ability to create precise policies, practices, and programs that are going to address the populations that are specifically in need, that we really need to pay attention to. But it was interesting that they found something very consistent with what we had found in our various reports and papers over time as well. And that this shorthand for using gender for talking about women and girls was something that they saw as consistently a pattern and a challenge that they found in the work that they were doing as well. One of the other key things I want to sort of acknowledge in this last part, before we get to sort of the opportunities going forward, is the definition of how we think about what equity means in the context of men's health. And so this is one of the things that they talked about in the context of this report, was you see this parenthetical reference to equity being distribution of resource, access, and opportunities, and equality for all. What you don't see is, interestingly, outcomes. And one of the interesting things that, has been a constant dilemma in the health equity space is, how do you define what equity is? And equity is, as I've critiqued in other contexts and spaces, one of the least well-defined terms, or one of the most inconsistently defined terms that we have in the field. We don't tend to use the same kinds of SMART goals, specific, measurable, actionable, so forth, goals, as we do for other health issues and for other metrics of success. We mention health equity a lot, or we talk about health inequities and so forth a lot. What we don't is actually usually include explicit measurable goals for that and explicit metrics of success for those issues. We treat it as though it is just sort of an abstract sort of objective, but then don't actually give it the precision that it needs. The problem with that is it tends to limit our ability to get the bodies that are focusing on it to include it as a specific goal and objective within there. It ends up just sort of being woven into other things, but not explicitly named and addressed as something that in and of itself needs attention. And in the context of men's health, in the context of gender and health, that has limited our ability to focus on the unique issues that are facing men, and specifically groups of men who have particularly poor health. So one of the outstanding questions that I'm not going to try to answer is, what should equity mean in the context of gender and health? How should we think about it when we think about people of all genders, not just men and women, but when we think about folks of all genders? And how should we think about it in the context of men's health? These are one of the things that we need. There are some of the things, clearly it's not just one, some of the things that we really particularly need to pay attention to as we go forward in this space. The last topic I wanted to briefly talk about is where are the opportunities that we have to go forward. And clearly, this idea of operationalizing equity is one of them. The other big one is to deal with, and this came up as well in the Lancet report, this idea of avoiding the impression of a zero-sum game. Now, for those of us in the men's health space, we've tried to do our best to avoid these concepts. You have seen, if you've seen me in different media sources, mention that these things are not a zero-sum game. Many other men's health advocates, supporters, researchers, policymakers have also used similar sort of language and so forth, where we're trying to show that improving men's health, focusing on men's health, getting funding and attention to men's health is not an effort, and explicitly is not an effort, to take attention away from women and girls and gender and health when we think about it as it relates to women and girls and folks who don't fit a gender binary. Yet this persists as something that has been a tension and a challenge. And again, in this report, they note, I could show you multiple examples. Ron Henry and I were both, we spoke on the media, actually it was a Washington Post article, I believe 2 years ago. Ron Henry is the president of Men's Health Network, and we're both quoted in an article in actually 2 years ago about this time, April of 2023, and where we talked about it's not a zero-sum game, or doesn't have to be a zero-sum game. We both got a lot of critical messages, let's just say, that suggested that they didn't agree with that. Well, I shouldn't say it this way. One of the things that I think I don't want to speak for Ron, but I think we largely sort of try to do in the men's health space is look forward and be aspirational. It's not to say that it hasn't been, well, there hasn't been attention to men's health, so it's hard to argue that there has been a zero-sum game. For those who have said, well, all health, to date has been around men's health and so forth, I say that all health biology or all biomedical health research has been based on male bodies. That does not mean that it's equivalent to focusing on men's health. Male bodies being the standard has not served men well, nor has it served women well, but it has been potentially the foundation of biomedical research, drug trials, and so forth. What that has not done is looked at men from a holistic perspective where we consider structural factors, commercial determinants of health, the ways that men psychosocially experience what it means to be a man, and other identities and structures that influence how they see themselves and how they are seen by others. So we have not treated, as much as I understand the problems with focusing on men as the biomedical standard, it is also important to recognize we have not really focused on men's health. And so there has not been an opportunity to look at whether or not this is a zero-sum game. And so that is its own problem. The second part is we are thinking forward and trying to be aspirational and saying it doesn't have to be this way. This is not our goal. This is not what we're aspiring to do. And so we are trying to work with you to find the opportunities to do that. One of the models that I want to lift up from a book that I just recently read. I know it's been out for a couple of years. I think this book came out in 2022. This book called The Sum of Us by Heather McGhee. And she, in this context, talks about this tendency to think about this zero-sum model as something that is quite common, particularly in racial politics, in the context of the US, but is certainly something that applies in the gender space as well. And what she says is, when she was looking for what are the ways to overcome this particular phenomenon, that one of the ways that we can actually look forward, and one of the things that she's seen be successful, is looking for what she characterizes as the solidarity dividend. What are the ways that we actually will mutually benefit, and that we can think about what is the commonality? What are the things that are common solutions that would be beneficial to all that we could actually work together and collaborate on? What are those sources of commonality that can unite us, as opposed to focusing only on the things that would divide us and that would make resources have to be split across groups? And so this is one approach, one framing that I think is particularly important, and particularly in the context of thinking about, sorry, let me see if, oh, I took it out. One of the things that's important in the similar paper that I mentioned, that I was showing the data on the life expectancy by race and sex in the United States, is that the 15 leading causes of death for men and women in the United States are the same. It's just that 13 of the 15 men have a higher mortality rate of dying from 13 of those 15 leading causes of death. But the point is, if you're looking for the solidarity dividend, what you might potentially do is think about what are the gendered patterns, or how would a gendered approach to the 15 leading causes of death in a particular country, context, or in our globe, how would those factors benefit from using a gendered approach? If we approached it that way, that may be something that could bear out and bear fruit of a solidarity dividend that we could approach, and not try to continue to have this same more of, if we focus on men's health, that is going to take attention away from women's health. I've mentioned implicitly intersectionality, but just lifting that up as something that clearly needs more, we sort of use it more, it has become a buzzword, and so it's lost some of the substance of what it is. But if we think about the ways that such an approach helps to disrupt the tendency to think of things either only through a racial lens or through a gender lens, and think of only things that where we need to focus on gender justice, absent the justice for other issues like race, ethnicity, and other sort of factors, this tension of fighting against ourselves or those who could be potentially allies is something that is an opportunity that we could easily fix by actually sitting down together and trying to figure out how we might collaborate and work together. Some of the other opportunities going forward, this is a model created by Rachel Tolhurst, who is the author and one of the other leads in the project that I was talking about for the Lancet series, future, hopefully, Lancet series, where she centers the importance of recognizing the broad ways that power systems, including racism, including patriarchy and other key factors, heterosexism being another one, that are structural determinants that we have to consider as we think about these major factors that influence men's health. And that using an intersectional lens to understand the social position of individual men or populations of men within that context will really help us to better understand, again, how to characterize, how to better develop strategies that consider the life course and factors like socioeconomic position and other other factors that operate, whether at the structural level or the individual level, that both have to be accounted for, that we have to account for individuals' agency and opportunities to engage in what they will choose to do as individuals, yet what are the contextual factors that shape what opportunities people have? But thinking about these things from this kind of level, where we give it this level of precision, is a really important part that Dr. Tolhurst really led in the work that we were doing together. One of the other key things, and then I'll close, is that we also, Laura Dean and myself and some others have used, and again, part of the same project, a combined syndemics and intersectionality approach, where we take these two things and put them together to help us create more and more effective solutions. The syndemics is an approach that basically anchors it. Basically, the simplistic way that I tend to describe it is it's considering factors or diseases that should not be co-occurring within a particular population group, yet they do. And it anchors why these factors co-occur within a particular population in the structural factors that actually shape why those factors have meaning for that specific population group. So, for example, we're looking at, well, why are heart disease and infectious disease like HIV consistently and persistently higher across the globe in men than in women? And what are the structural factors that contribute to the fact that men have higher rates of mortality from these things that mechanistically really don't have a whole lot to do with each other, aside from things related to perhaps an immune response and just the weathering process overall? But they should not be related. If you think about the ways that these diseases that you contract or develop these diseases and so forth, they should not conceptually be related. But a syndemics approach helps us to think about, well, how and why are they so consistently related, and points us to these structural factors that have not been consistently part of the picture that we use to think about how we understand or better understand men's health and the determinants of men's health that we need to use to intervene to address these larger issues. And then intersectionality allows us to add a level of precision to that, to look at specifically what are the ways that specific population groups within a given context, that those particular structural factors operate within there. And so for me, I've used this in the context of Black American men and COVID to look at why Black men had higher rates of mortality from COVID. I'm not going to remember exactly where the context was that she was looking at it, but Laura Dean is the colleague who has done this work before in, I believe it was in war zones, where she had looked at these factors, and again, a variety of things that should not have co-occurred, yet were disproportionately affecting men in that space. So what we did today is just walk through, again, some of the considerations, challenges, and opportunities as it relates to men's health equity. Complicated the picture a bit, but hopefully often gave us a way going forward. We have to figure out, a way to create the future that we want, but we have to envision what that would look like, and we need to add more precision to how we do that and how we think about those issues, and better defining what it means to be, what men means, what health means, and how health equity should be operationalized in the context of men's health are things that are really critical and important to that picture. A couple of closing thoughts I just want to leave you with is, what if we actually centered this focus on equity and this focus on marginalized men in the context of men's health? What if we moved it from the margins to the center and actually said that we needed to design programs, policies, and practices that actually serve them, recognizing that if it serves the least of these, it will serve those who have more resources and opportunities that would then also be able to benefit. But if you start with those who are going to be the most difficult to reach, and you're able to successfully reach them, how would that benefit our ability to achieve these larger goals, including improving men's health? And what if we actually used an intersectional approach that didn't just center gender, but as we've seen in other contexts, really do consider other factors, race, ethnicity, and other structural conditions and contexts that are equally important in the context of determining men's health, that we need to really consider if we're going to understand the full set of factors that really determine the outcomes that we see. Gender, in some cases, in many cases, is not the primary determinant of why men have shorter life expectancy in a lot of these areas. It has more to do with the other structural and commercial factors that are contributing to the health issues that we're seeing. So it is important to recognize those. Let me close with a bit of a somber but important note to remember. 5 years ago next month, we have the anniversary of the murder of George Floyd, and the importance of recognizing the ways that this changed how we thought about what was important in our society, what were important in the goals that we set, what was important in centering equity and related issues, and how across the globe there were folks saying there's a George Floyd in every country, and the importance of recognizing the solidarity around these issues of broadly structural inequities and how they have played out in related countries. We're seeing a pushback against that, and we have to figure out how we are going to respond individually and collectively in this moment to this particular phenomenon. And so the last question I just have is, what then are you prepared to do to advance the agenda that you have, to do the work that you should do, and to focus on men's health? Thank you.
Well, thank you very much indeed, Derek. That was an amazing presentation, amazing lecture. And what you managed to do was to be both succinct and comprehensive, and challenging and inspirational. It was really very important, a very important and useful presentation. So thank you very much indeed. We have a few minutes left, about 5 or 6 minutes, to deal with some of the issues that have come up in the chat. And while you've been talking, you probably didn't notice, Derek, but there's been a very lively conversation going on in the chat. It's been quite amazing. And we will pick up some of the issues that have been raised in the follow-up to this presentation. So we will be getting in touch with everybody who registered and attended this webinar to perhaps answer some of the questions and provide information, and send you the recording and the slides. But one of the issues that came up, Derek, is about men's use of health services and the barriers. And I wonder, I don't think you really went into that in very much detail. So I wonder if you could just say a few words about the issue of equity in relation to men's use of services, and what some of the barriers are and how they can be overcome.
Yeah, so it's interesting. The other, again, I hate to keep using the US context as an example, but one of the other things that happened recently, actually it was, I believe, last year, there was a report that was published in 2003 initially called Unequal Treatment, that was basically trying to look at the quality of care were there racial and ethnic differences in the quality of care that people got by race and ethnicity when you controlled for access to care? So when you had the same level of insurance, had the same income, and had the same other factors, and were even in the same facility. And we saw that persistently, they looked at 10 years of studies and over 100 studies over that period, and found that there were consistently racial and ethnic differences in that time. 20 years later, they repeated the report, repeated the analysis, and basically found that there had not been significant progress in those issues. I say that to say, and then I think you and I have talked, and folks in other contexts have talked, that even in places that have universal health coverage, that we've seen some racial and ethnic differences and differences by other factors, certainly by gender identity, sexual orientation, and other factors that have been persistently different regardless of how men sort of present and identify themselves. The point is, we have to look at this from an intersectional standpoint, and that gender is only one of those parts and pieces to that. And we've seen these literatures run largely in parallel, but we haven't seen them come together. It's going to be important if we're going to be successful in these broad areas for actually us to bring these bodies of work together and to see how they can inform each other and how they can enrich our ability to do that. I don't think our systems are prepared to serve. One of the things that we've tended to look at is what do we need to do differently for men in these spaces, but what do we need, how do we need men to be different in these spaces in terms of being more prepared to go seek care? My question is, are the systems really prepared to have men seek care in these spaces? When men do present, they often are not reporting that they've had great experiences, that they felt well respected, that they felt their needs and issues have been adequately considered and addressed. So it's one thing to get men to go to a system, but it's another thing that the system may not really be prepared for men to show up. So we've got to operate and work on both ends of this if we're going to be successful.
Thank you. One of the other issues that came up is about political advocacy on men's health. I mean, one of the great puzzles about men's health is that the stats about how bad men's health is, or some of the men's poor outcomes, they've been there for years. It's not like this is a big secret that is only just being revealed. But nevertheless, these issues, as you rightly said, haven't been at the forefront of policy and research. So is one of the reasons, do you think, a lack of political advocacy around men's health? And how might we overcome that? What can we do to increase the engagement of politicians and policymakers in this issue? What are we missing?
Yeah, I think you and I have had many conversations about this, and I don't know that I have any better answers than you do, or Ron Henry in the US context does, or Richard Reeves, or any of the other folks who have been seminal in trying to push these kinds of issues. I think some of it has to be considered in the larger context of the narratives that men often how we understand, both as men and as advocates, as well as men who may just need their own help and support. How do they understand why men have poor health, and what are the issues that they think are worthy of seeking care, are worthy of addressing these issues, and how do they understand that? How do women's health advocates and so forth, how do we, what are the narratives that survive, how we that explain, I'm sorry, how we actually think about these issues. Sorry, it's distracting watching these things pop up. And so I think the narratives have shaped some of the, for lack of a better saying, apathy or lack of sort of being able to create a coordinated response to addressing these issues, because we tend to think of it as, oh, well, men are advantaged and men have these resources and opportunities, and the only thing that we need to do differently is that men need to go seek care. But men have the potential, all of their resources, and the only thing that we need to do is figure out how to motivate men or kick men in the butt virtually to be able to do that. And that doesn't leave a space or an opportunity for a policy response. It doesn't give space for others to have a role in that. It's just saying, if I can continue to nudge, and I'm being gentle and characterizing it as nudging men to do what they're supposed to do, then the problem would be solved. And so, as opposed to realizing that it was actually something that was more potentially structural in nature, or at least has a structural component that we need to consider. So I think we need to work harder on the messaging, on the narrative, and how to think about motivating men, or think about what those advocacy messages would be that are going to help us counter those larger narratives.
Okay, thank you. Just one final question, so we do have to wrap up. We're over the hour.
Sure.
But
Yeah.
you mentioned that the recent Lancet Commission on Gender and Global Health uses the concept gender justice. And it actually wasn't a concept that I was familiar with really until that report came out. And I wonder if you think that term is helpful to us in the men's health movement, if I can put it like that, or whether you think there might be a better, whether we should run with that, if you like, and go with the phrase gender justice as a way of talking about the equity issues that we're interested in, or whether that could continue to propagate the idea that gender and gender issues are women's issues, which of course we know is not the case.
Yeah. Um, it's a great question. I think I'm increasingly wondering if it's a question that we can answer ourselves, or that we need to get into spaces with those who we want to share this potential solidarity dividend with, and figure out what are terminology, what are languages, what are narratives, metaphors that we're all comfortable with. What are the things that we see as potentially ways that we need to share these issues, and that we can find some common ground on which to build our shared interests and be able to address these things together. Um, Many of us in the mental health space have lamented feeling like we're in an echo chamber and we're only talking to ourselves. So the problem is not advocating within each other, within ourselves. It's how do we actually engage others? And I think we just have to be more humble and just ask others, okay, so how do we grapple with this? What are things that are going to make this okay for you? If zero sum and not having a zero sum game is not going to do it for you, all right, then what is the thing that we need to do? But I think we have to reach out and figure out what is something that a terminology, a framing that would actually be acceptable to a broader range of folks that we want to have a shared benefit with.
Okay, thanks very much, Derek. Well, you've given us a lot of food for thought there, as well as inspiring us to continue with the work that we're all engaged in. So I need to wrap up, but thank you very much indeed for your excellent presentation and answering some of the questions and some of the issues that came up in the chat. I'm afraid we didn't have time to deal with all of them, but as I say, the conversation can continue. And I
Absolutely.
urge everybody who doesn't know about global action to find out more about us. Go to our website, gamh.org. And I hope that you'll be interested in joining with us and collaborating with us and working with us as we take these issues forward. So thank you very much, everybody, for joining this webinar today. And thank you again, Derek, for such a fantastic presentation. So on that note, I will wish you all the very best and say goodbye. So thank you, everybody.